channel viewers. In today's video tutorial, we have covered in detail about the recent advances in the management of gastric cancer. Highlights of this video tutorial will be AJCC classification, anatomy, TNM staging, the lymph node station according to the Japanese classification, the extent of lymph node dissection as per the Japanese latest classification, lab versus open distal gastrectomy in early and advanced gastric cancer. Then we will discuss about perioperative chemotherapy and reconstruction option and Korean practice guidelines that we have covered in the last part of the video tutorial. So now, in this part of this video tutorial, we will discuss about different type of lymphadenectomy and their classification as D1, D2 and D1 plus, D2 plus, and what are the lymph nodes removed during total gastrectomy, distal gastrectomy and proximal gastrectomy or pylorus preserving gastrectomy. So stay tuned. So when lymphadenectomy does not fully comply with the D level criteria, lymph node station additionally resected or left in situ would be recorded as in following. For example, if we have removed perigastric lymph node, that is 1 to 7, and additionally 8A, or we have done D2 gastrectomy plus splenic hilum lymph nodes are lymph nodes are not resected, then we can write that is D2 minus number 10. So what are the lymph nodes removed if we are subjecting the patient to total gastrectomy? So in a patient in whom we are doing total gastrectomy, so the D0 lymphadenectomy will be less than D1 when we are moving less than 1 to 7 lymph node station. D1 will be when we move station 1 to 7. D1 plus will be like 8A, D1 that is 1 to 7 plus 8A that is common hepatic artery and anterior superior. 9 will be your celiac axis and 11 will be proximal splenic artery lymph node. Or D2 when we removed 1 to 7 plus 8, 9, 10, 11 and 12. So in this picture, which I have taken from Japanese gastric cancer treatment guidelines, the tumor invading esophagus D1 plus will include 110 and D2 will include 19, 20, 110, 111. The complete dissection of lymph nodes in blue color denotes D1, that is 1 to 7. Nodes in orange will be D1 plus, and then if we remove all the nodes including blue, orange and red, that will be D2 for the total gastrectomy. So for D2 gastrectomy, we will remove lymph node station from 1 to 12. So for if we are selecting the patient of distal gastrectomy, the definition of D1, D1 plus and D2 is different. So as I said, the lymph node station or D1, D2 lymphadenectomy in distal gastrectomy will be different, and we have to understand the anatomical basis. When we are doing the distal gastrectomy, the proximal stomach, the remnant to which we will do the gastrogenostomy, will be supplied by the splenic short gastric artery based on the splenic axis, splenic artery. So we will clear the lymph node 1, 3, 5, that is along the lesser curvature of the stomach, and 4, S, B and D, that we will leave the short gastric lymph nodes behind, and we will clear the left gastroploic and right gastroploic and infrapyloric and left gastric artery for D1. And so station 2 and 4SA, they are not dissected out in distal gastrectomy as per the lymph node station. For D1 plus, additionally 8A and 9, that is anterior superior common hepatic artery and celiac trunk lymph nodes are removed. And for D2, we removed additionally splenic artery and proximal and splenic hilum lymph nodes. So again, in this we will not disturb the 11D part because that is the part of nourishment to the short gastric arteries. Picture, complete dissection of lymph nodes in blue denotes D1 dissection, and nodes in the orange will be D1 plus, and nodes in the red will include D2. So if we are doing pylorus preserving gastrectomy, what will be the extent of lymphadenectomy in these patients? So for pylorus preserving gastrectomy, the D0 will be lymphadenectomy less than D1. D1 include 1, 3, 4 SB, 4D, 6 and 7. So when we are preserving the pylorus, we are leaving behind the lymph nodes station 5 because the pylorus is remaining there. So, and that will be supplied by branches of right gastric arteries. So it will be not dissected out. So 1, 3 and 4SB, 4D and short gastric, because the proximal remnant stomach will be supplied by the short gastric artery. So we will not dissect the lymph node along the short gastric artery. So 4SA will not be dissected out. So 1, 3, 4, 6 and 7 will be taken out. And for D1 plus, additionally 8A and 9, which is similar for all the lymph nodes, are taken out. The complete dissection of nodes in the blue denotes D1 dissection, and nodes in the orange includes D1 plus. So if we understand the anatomy of dissection or the gastrectomy, we can make out which lymph node station we will dissect out and which has to be left behind, as we cannot compromise the lymph node supply of the remaining organ. So coming to the proximal gastrectomy dissection, we are leaving the distal stomach in situ. So we will clear the 1, 2, 3, 4 and 7. So distal lymph node, that will be 5, 6 and 4D. That 5 is suprapyloric, 6 is infrapyloric and 4 is around the right gastropyloric, that are left behind. And for D1 plus, 8A, 9, 11B are taken out. For tumor invading the esophagus, D1 plus also include 110, that is lower thoracic paraesophageal lymph nodes. Complete dissection of lymph nodes in blue denotes D1 dissection, and nodes in the orange will denote D1 plus lymphadenectomy. Okay. So in principle, D1 or D1 plus lymphadenectomy is required for T1N0 tumors of gastric cancer, and D2 is required for any tumor in which there is a clinical suspicion of lymph node positivity, or any tumor which is T2 and above. The D2 lymphadenectomy should be if the nodal involvement is suspected intraoperative. There is no requirement of splenectomy unless tumor either directly invades the spleen or is located in the gastric curvature upper stomach, which is impairing with the lymph node harvest. There is no benefit of periodic lymphadenectomy, which has been proved by randomized trial JCOG 9501, which is a Japanese trial.